The nice part, the length is the easy part also. You take your high lip line, and the high lip line, like here on the picture here, is 7.5. I want to add 2 to 3 millimeters. In this particular case, I'm going to go 3 millimeters. So I would want at least a 10.5 length tooth. I mean, isn't that simple? Just by going with high lip line. If I was going to do this patient, 8.5, add 3, I'd want 11.5. So really quite simple to figure out the length of the teeth. Instead of asking Kelley Dental Lab to choose a length by looking at a cast and trying to get the measurements correct for that, it didn't involve the patient in it. You don't know what the smile is like. You give us these measurements, we know how they're smiling. We know where we should be putting the teeth. Here's another one. You can also measure the patient's ala. You're going to use the widest part of the nose, and you would actually use that, and it gives you the measurement from the center of the cuspids and gives you the width in millimeters. Also, you can use any calipers or a ruler, and you can measure the patient's inner canthus from this eye to this eye. That will give you to the distals of the laterals. Some people say the mesials of the canines. And what's really kind of neat, you can take both of these calipers and you can turn around, you can do a ruler, like I said, or a Bowley gauge or whatever, and you can turn around and you can grab 10 sets of teeth. And you actually will take your calipers and you'll just place them on the teeth as you're going down the line. And you can say, oh, that's too big, that's too small, this is too little, this is too big. Anyway, you can pick out teeth so much easier. But there's an easier way and a better way to do this also. We use the blue line form selector.
The form selector is a fan-shaped device that is designed to facilitate the selection of the maxillary anterior teeth. It consists of a facial meter and a series of cards that represent all the maxillary anterior molds in actual size. The facial meter is used to determine the width of the patient's nose. The tips of the meter are carefully placed adjacent to the widest part of the patient's nose. The meter is read below to determine what size tooth would be most appropriate for this patient. In this case, it measures for a large tooth mold. Next, we unfold the tooth cards and expose the 2 cards of large molds. One card is composed of large, bold tooth molds, and the other large, soft molds. A decision is made whether a soft or bold design would be best appropriate for this patient. In this case, the bold card was selected. The 1 card is isolated and placed in juxtaposition to the patient. This gives the dentist and patient the opportunity to view a handful of selected molds immediately adjacent to the patient's face. Although the final decision of mold selection is somewhat subjective, it is greatly facilitated by having only several molds from which to choose from. The teeth on the card are arranged from short to long, and each mold has some variation in form and surface characteristics. The tooth mold selected for this patient was of medium length, and the patient and dentist approved the characteristics of this particular mold. As you can see, the form selector greatly facilitated the tooth selection process. The patient and dentist certainly have the opportunity to review the selected teeth once again when they have been set in wax for the try-in procedures.
With the blue line form selector, it is so nice. This is the blue line form selector. It has calipers. And these calipers, I can turn around and place on my patient till it touches. And it goes to an area here. You know, mine's actually medium. So it goes to the medium. All I have to do now is to go through. These come in small, medium, and large. So I go to the medium, I'm going to take all the others away. And as you can tell, I have medium, soft, and bold. Now, what's really nice, the way I like this, if you look really closely, the first one here is 49. The next one is 51, 49 and a half, 50 and a half, 49 and a half, 50 and a half, 51. All of these were within 1 to 2 millimeters from the other one. Then you divide by 6. So do you really think 2 mil? If I pick the largest one, does it really matter that I picked 2 millimeters longer or wider? No, it doesn't. What's going to make the difference is the length. This is what you have to be careful of. So what we do, we go to this, and if you notice the patient, let's say the patient is kind of, you want to do soft, you can drop this totally, and you can show this to the patient. And you ask the patient, is there any particular shape that you like? You're going to be amazed how your patient's going to look at you, and they've had dentures made for years, and they'll go, no one's ever asked me. Why? Because we just automatically take an impression of the cast, and then we just send it to everybody, and we just keep moving. It's just, it doesn't even do us justice to be able to just keep copying people's old casts. This way, you'll find out that a lot of the patients will say, I like this one. And you go, why do you like that particular mold? Why did you pick an A36? And they'll go, my daughter has teeth like that, or I have an uncle, or my father had gorgeous teeth. And that's the shape they were. Perfect. I would tell you to go and copy this on your copy machine, circle it, have the patient initial it, and then put it in the record. And make sure that that's the teeth that you let them try in. And that way it's good for the front office. If they call you up and say, I just lost my right front tooth, you'll automatically, just with a picture, know what mold it is and everything. But you just have to be careful with the length. If they pick this tooth here, and I need a 10-8 tooth, if you'll look, if I hide here and hide here, they're really the same shape. I just need a longer tooth. So it's so easy just to move in and transition to that. But you're going to be totally surprised how the patients love doing this, and it's very easy. And it doesn't take much time to do it. Next, we're going to turn around. The laboratory is going to do all of this, of course. All of this takes you, I guarantee you, 5 to 7 minutes, or you can have your assistants do these measurements, and then you come in and check. They could do the denture gauge from the existing denture. They could also try the papillometer and get a measurement from the patient. You go in, verify, plus, then you start letting the patient smile, let them, do their phonics, 55, 56, 61, 62, 63. And remember, 50, 51, father, you just want to make sure that the incisal edge is touching the lip. Either occlusal rim or the trian. You want to do the same thing when you come back to the trian. And then the laboratory now is going to they're going to take a rim former.
The rim former is a tool that facilitates the fabrication of wax rims in a laboratory. It could also be used clinically to adjust the rim during the wax rim try-in appointment. The rim former has a 5mm fence on either end and a wax spillway in the center. The tool has been designed so that it can be used either by a right or left-handed person. We're going to try in the wax rims and have the patient relax his lips. Typically, I like to have the patient count 1 to 10 or to have them converse in a casual conversation so that we can evaluate the incisal length of the wax rim.
2, 3, 4, 5, 6, 7.
I think we could agree that the rim is too long for our patient, so I will mark where I think the rim should end, and we will adjust the wax to the desired length. The rim former is heated over a flame, and the 5mm fence is positioned over the hammer notch area of the denture base. The rim former is slowly brought forward, melting the wax up to the designated mark. Note how the melted wax is automatically guided through the center spillway.
You're probably accustomed to seeing this big old thing. And you know, and everybody kind of makes an occlusal rim, and they melt this, and they just keep doing this and this and this, and everything's crooked. One side's melted and one side's not. You're going to find out that we're going to use this rim former, and this rim former not only keeps us straight, so one side is not leaning. You're not going to have left to right leaning, but it also takes it all the way up to the tuberosity to 0. So you already have a nice curve of Wilson already going when we send this to you. The lower anterior is long, and it just goes to 0 back to the tuberosity. And you're going to see how important that is in a few minutes. So what we're going to do, the laboratory, we're going to turn around and we're going to take the hammer notches. Of course, this is the hammer notches. I have it marked in dark pencil here. We would turn around and we're going to make a base plate, of course, but we're going to take away a little bit of the base plate here. We're going to make a little U shape, so that I can get this little flange inside of that to be on top of those. Why is that important? Over 90% of the time, your hammer notch is parallel with the pupillary line. Can you imagine going to go gamble to the casino and you win money 90% of the time? 90% of the time, you're not going to see left and right. Right side hanging down, left side's hanging down. It is automatically going to go with campers playing that quickly and that simple. And all we have to do is we heat this spatula up. Instead of using the big boy, we're just going to heat up this spatula. I have one that's a two-sided one that's in the picture there. That's for a left-handed and a right-hand or a right-handed person. This is a right-handed. I've had this one for 30 years. Still in good shape. And all we're going to do is heat it. And we have our occlusal rim totally longer, of course. We turn around and put the measurement that you gave us, and we made a mark on our wax. And we're actually going to take this, put it into the hammer notch, and we're going to turn around and we're going to press and go down and down and down until we get to our anterior mark, and we're going to stop. And it's going to be amazing how it's going to totally be nice, straight, and when you put it in, it's going to go with camper's place really nicely, which I'll show you in some pictures. But this is all we have to do with this. And so you can see here, we just melt. The important part of all of this is making sure that you keep that flange touching the hammer notch. If you let it lift, this is going to be a little crooked. So you're going to want to make sure it stays in there very nicely. And that's the reason why you saw me moving the cast towards the plate, not moving the plate towards the cast. Because as that wax starts chilling and my plate starts chilling, it'll lift. So I always want to have this very tight. I'm pushing and pushing back, and that way I'll take this to the plate instead of taking the plate here, because then it can lift on me, and I just don't want it to lift, because I want this perfect for you. I don't want you touching the occlusal rim. Kelley Dental Lab does not want you spending any time on this. We want to give you that ECB, and it's perfect, and we just want a phone call going. That is the fastest occlusal rim try-in I have ever had. And then when we send you back the setup, you're going to see the setup is exactly like that, and your setup's going to go very quickly. This won't happen. And I know a lot of you have gotten occlusal rims that the laboratory makes 22 and 18, but they make it like normal. And what's going to happen is it's too long in the back. What's really nice, we're using the rim former. When I put this in here, the anterior is long, but it goes to 0 here. So you're going to see that the occlusal rim is not hitting that hard in the posterior section. It's only going to hit in the premolar areas. So here's what we're going to have. So now it's going to hit in the premolar area, and you're going to have this slight opening. Now what usually happens, which is another mistake that we kind of make, we put some bite material in there, we have the patient open, and we have them closed down. Anytime the patient starts closing, or you put your hands in the mouth to hold the base plate, you're supposed to hold the base plate up, you're supposed to hold the base plate down, and then you kind of jack them around and move them around, and then they're supposed to close down. This is so difficult, it's incredible. There's no way. I mean, there's no way you can do all of that. So what we like to do is just have the patient open, close, open, close. You're watching those, we put those lines in the anterior for you. You want to make sure that they're lining up properly. You're making sure the patient's not going left or right. If they do, you go, you're going to your left, you're going to your right, but you can tell when they're not going straight up and down. And then you can turn around. Once you have those and you practice with them and they're going straight up and down, you definitely don't want them to open again. So what I'm going to want to do now is say, now keep that together. I want you to bite down, stay on those occlusal rims. I'm going to pull your cheek out, and now you're just going to squirt some bite material right here. You already put some notches on this, and you can just put some bite material right there. So they're not going to bite, because if you tell a patient to bite, they always want to incise. They always want to come forward. Anytime you say bite, it's just going to happen. So we don't want them to do that. Just close, and then have them bite right into the material, down into the occlusal rims of the wax material, and then just squirt the material inside that little opening. You're going to find out if you measure from vestibule to vestibule, and it's usually supposed to be the deepest part of the sulcus, so it'll be in the lateral area. A lot of times we've been taught to measure from the frenum. It's not a good place to measure. You just want to always measure in the deepest part from lateral to lateral. And you're going to find out generally your patient should be 36 to 40. There was over 2,000 skulls by Dr. Bonwell, and they found out that, that's where, 90-something% of the people, this is where their vertical was, 36 to 40. That's where you get the 22 and 18. 22 and 18 equals 40. So that's where it came from. Also, that 40 measurement is really not an anterior measurement. It's actually a posterior. It's actually from the center of the condyle to the angle of the ramus. It's usually 40, and we reference it for the anteriors. Now it's time to do our Fox plane. We did the occlusal rim, we put it in, we actually went through the phonics. Remember, we went through 50, 51, 52, 53, saying the F's, father, 55, 56, any F sounds, and you just want the occlusal rim to touch here, or if you're at the tri-end stage, the anterior teeth edge, barely, father, 55. Then you're going to want to count 60s, 60, 61, 62. You're trying to see if the occlusal rims or the teeth are going to hit when they say 60, 61, 62, 63. If they hit, you have violated that inner arch spacing. That neutral zone has been violated. If they do, you just want to close it down 3 to 4 millimeters, because you want to always have 3 to 4 millimeters of nice, we used to call it freeway space, but I've been told by many of our prosthodontists that it's not a freeway. You drive on a freeway, it's inner arch spacing. So I have to watch what I say, and or they'll slap my hand. So now we're going to put the Fox plane in.
The bite plane has an intraoral component that rests against the maxillary wax rim, and an extraoral extension that will help us visualize the horizontal aesthetic plane and the occlusal plane. By resting the bite plane against the maxillary wax rim, we can determine if the rim is parallel to the interpupillary line. By viewing the patient from the side, we can determine if the occlusal plane is parallel to Camper's line, which is a line that extends from the tragus of the ear to the ala of the nose.
We've made sure all that is correct, put the Fox plane in, and you want to do it holistically. You're going to actually want to look at the forehead, the eyes, because if you look at this gentleman, his eyes are not parallel. If you look, one eye is a little bit lower, but I want to holistically look. Sometimes you could place a tongue depressor here, your assistant could put another tongue depressor here, and then you're looking at the front of your Fox plane, because you want to make sure that is running totally with your holistic lines. If one side is leaning down, that's exactly what you're going to get back when you do the try-in. The try-in is going to come back and they're going to lean because that's what you gave them with the occlusal room. So that you're going to turn around and just verify that it's straight. I know I told you 90% of the times the rim former is going to make that perfect. Well, if it doesn't, the nice thing about this, if one side's a little longer, what I really like about this, we can heat this. I can come over here just to this side. If this side's a little too long, I'll actually put this in that hammer notch and just relieve just a little bit of that wax until I touch the anteriors and I stop. That way I don't relieve any of the length of our occlusal room we already have. So instead of just taking this, sorry about that, making that noise, you know, this is just, you're trying to do by eye. I would rather use a hammer notch because I know the hammer notch is going to put me there 90% of the time. Then you want the patient to go laterally, and now you want to check Camper's plane. Camper's plane goes from the ala to the tragus of the ear. So I want to make sure this distance is the same here and here. If all of a sudden this is leaning down this way, then I'm going to have to pick that upper up. I'm going to have to relieve the upper occlusal rim some more to get this straight. But generally, you're not going to touch it. What if? What if it is leaning? You know, 90% of the time, Kelley is right on it. They're always perfect. Well, what happens if it is a little bit crooked? Well, you have two options. You can do as I was showing you a while ago. I would turn around and I would actually look. Number one, I would look to see, do I like the incisal area being a little long on this side? Or do I like the look of the occlusal rim being a little shorter on this side? You have to know which one you want to do because that's going to, you either got to add to this side or you got to take away here, or you can do what I'm going to show you here in a few minutes. This way you don't have to break out the heat, you don't have to bring out the pads, so you don't have to do anything, you don't have to add wax, you don't have to spend chair time. You can just take some bite registration material, place it on the occlusal part of the Fox plane, or the bite gauge, whatever you want to call that, and just straighten it up. That is quicker, it's faster, and it's easier. But again, you just have to remember what side do you like, because on the prescription, you're going to have to tell Kelley Dental Lab, I want to stay with the patient's left side, I want to stay with the patient's right side. One or the other. And this way you don't have to touch this. And now what we're going to do is you take that off, and then you take the prescription, and you already have the prescription here. You've already given the papillometer measurements. You did the denture gauge. Those are already been on there from us making this. So those are always still there. And this is how you get that information over to the laboratory. It's on this type of prescription. But you have to say, I like the left side or I like the right side. So we're going to mount it. We're going to put it on our flat table. This flat table is going to be set at 0, and this puts this case totally in Bonwell's triangle. It's going to put it exactly 104 from the center of the condyle to the lower anteriors, which is where 90% of the population already is there. So you don't have to take a face bow, just as long as we're not going to have to open and close your vertical. I don't need a face bow. If you're going to open and close your vertical a lot, anywhere from 3 to 5 millimeters, and then I need arc closure, then I'm going to need that face bow. But if you don't do that, I don't need it. This works perfect. This is called average value. We're going to line up the labial part with our line here. The midline is going to line up here, and that's the one thing I forgot to tell you. You look at the lines that we put on there for you. If that line is straight there and it's not quite in the middle, then you just take and you'll scribe a new line to the left or to the right of it. If it needs to go left, you go to the left and you do a little bitty line. I've had one of my doctors call me up and they say, well, how do you know which line's mine, which one's yours? I went straight down the median raphe in the center of the papilla. Anything left or right, I know you did it for me, so I don't have to guess. And that way, you know, if that's not correct, you can go ahead and do that. Because most of the time, when you try to mark that, you try to pull the patient's lip up and then you're marking, most of the time you're leaning over the chair. And if you lean over the chair, it's always that midline is always going to come toward you. And so it's going to be slanted slightly. So that's the reason I like to put the line up there for you, so that you've got a guide. So now you can lean over the chair and you can mark it. Even better, if you turn the patient sideways in the chair, you're sitting in your chair and you're knee to knee with the patient. It's so easy just to go whoop, and mark it that way also. So whichever way you want to do that it's fine. But it's nice to have that initial line there, and it's not your midline unless you tell us that's where it was. Majority of the time, it's going to go down that median raphe into the center. So yeah, I'm still also doing that so it saves you time. So we're going to mount those midline, and we're going to do the labial position. So we always have that position for you. Now we go ahead and take the bite off, the registration off, and you can see the big gap here. And you're going to look at me and go, wait a minute, Don, you didn't mount that correctly. Sure I did. That's exactly what you had here, but you put the bite material in, and now that becomes my aesthetic plane. So once you did that bite material, you gave me my aesthetic plane. Now, if you said, Don, I like the left side, we don't have to do anything. All Kelley Dental Lab will do, they'll set the central, the lateral, the canine. Over here, they will make sure to bring the central down farther than that occlusal rim, and the lateral down. Canine, first premolar, second premolar. Because this is your aesthetic plane here. It is not using the occlusal rim, because you did not try to reduce that. You gave us this nice bite registration here to straighten this up for us. So that is our new aesthetic plane. If you like this side, all we have to do at Kelley Dental Lab is we will reduce this side, raise the plate up until it's solid on this side. So either way, we raise or lower, or we keep it where it's at, which you make that decision, and we go from there. So it really makes it nice. What really makes this nice is, let's say we tried it in and you did the best you could, and the patient says, you know what, I'd like to show another millimeter of tooth, or, I don't show as much as I'd like to. I'd like to show a little bit more tooth. The real nice thing about this, Kelley Lab has to just drop this. These have millimeters on them. We drop it 1 millimeter. And what's really nice, when I go back, I already know where your midline is. I already know where the labial was, even though I moved this. If I don't have this, then I have to bring the tooth down, and then I've got to try to use my hand to hold another tooth, and I pull that one down. I don't have anything to make sure I don't pull them out, pull them back, or that I get leaning left and right. So this little bitty setup plate is absolutely a necessity to make sure the teeth always get set properly, labially, incisally, and you don't have it leaning. I really like the way the plates do. Unfortunately, my first 12.5 years in business, I didn't have this plate, and I did everything by eye. And if I had a good technician that was really good with his eyes, her eyes, then they did good setups. If I had a technician that couldn't tell whether they're leaning left and right, we kept doing resets. So this plate just automatically, this flat magnetic setup table just took that away, really made it really nice. So I'll go back to where we're at here, and we're going to get you back here, and we'll make those changes for you, and we'll get your aesthetic plane. What's even nicer if you have to move the teeth up, because as a technician, we'd have to take all the teeth off and then start your setup totally from scratch. So we could get off left and right if we're just hand holding a setup template in our hand or a flat plate. It just makes it more difficult. So this gives you precision. I really like this magnetic flat setup template that Ivoclar made and goes with the Stratus Articulate. Now let's get to our what's the difference tooth lines. I get calls constantly from laboratories and doctors saying, what tooth should I use? And I'm going to show you 3 premium tooth lines. Yes, of course, we have some economical teeth. We have some economy teeth that you could use. I personally do not like it. Even if I'm going to do an immediate denture, I usually like to use a premium tooth, and we just reline it, or I'll go back and make a brand new case. But it's kind of tough to make a preliminary denture for someone, and then you're going to change, because you can't always get the same mold, can't always get the same color, and then you're going to make a definitive denture later. Patients don't like that because people see them, they get used to them, and now all of a sudden you're changing them again. So I'm one of those kind that I try to use, premium teeth on anything that I do. And it just makes life simpler at the chair. You don't have to fight your patients. You don't have to make excuses and say, I apologize, these teeth are not going to be what your final case is going to be. I always want to be part of making the patient happy from the day they sit down to the day they leave. So here's these three here. It's the Veneris 2s, the Vivena S PE, and the Vivena S VCL, and then the blue line. I'm going to go very quickly on that just so you can see this. The Veneris 2, they're my favorite. I try to use these every time that I can, but there's some caveats. The Veneris 2, number one, you're not going to find the shapes. If a person wants to keep exactly the same shape as their teeth, their existing teeth, or their existing denture, then you're not going to be able to copy that. These look like teeth, so they may not have a denture that looks like real teeth, and they may be real, triangular or real rounded or whatever. These teeth are definitely age specific. So if you look, we have a youthful, we have a universal, and a mature. These are the only three shapes we have. All we did was made a small, medium, and large, and then we made a soft and a bold. So that is it. But the beauty of these teeth are just incredible. Plus, they are composite tooth, so therefore you cannot find a tooth on the market that has better wear than these particular teeth do. I mean, they're just incredible. These teeth are doing really, really nicely. You don't see any wear on them. They're just doing really a great job. But again, you can look at these. I mean, you look at the youthful, the universal, and then the mature, and we'll talk about them real quickly. Again, they do come in a soft and bold, each one of these, and there's like 3 each of these for those. But what I really want to show you is, number one, youthful. Why do we call it youthful? Well, if you look at the incisal edge, it is very rounded. If you look at the labial, it's very rounded. What a youthful tooth would look like. And then you look at the universal. The universal, you're not quite as curved, and you have a little bit less curve here on the labial. And then when you get into bold, mature person, then you're talking about flat, and you have a flat labial. So that's where the age specific comes from. But what I really like to show everyone, even with the patient, I always turn the denture to the palatal side. I always want them to see, because everybody sees the labial and the smile, but look at this. I mean, you have never seen a most beautiful tooth. Look at the opalescence. Look at it has a real cingulum. So I can actually make my wax proper, and believe it or not, when they start speaking, where does the tongue go? It hits this area. So if we have wax all the way up here and you come straight across because there's no cingulum, a natural cingulum, it affects the speech. So this is very nice and contoured properly. And if you look at the labial, look at the incisal. I mean, look at that opalescence. I mean, that is exactly where your crown and bridge would make these cases. And so you don't have to have a denture that looks like dentures. This looks very natural. Look at the subtle little embrasure here. What I really like also is we have widened, instead of having this square tapering, square ovoid, or tapering, the teeth have been widened here. So the necks are wide all the way down. But look at that nice interdental papilla there. Look at the emergence profile. It is very natural. If this was a regular tapering tooth or an ovoid tooth, I would have to bring my wax all the way up here to the contact point. That's not natural. You don't have tissue coming all the way up to those, to almost the size of a third of the tooth. It's just not natural. So that's why I like these. They make me look good. I can be a very poor technician, but these are going to make me look good. I mean, that's sad to say, but the materials, the teeth, and the acrylic make or break a laboratory technician. Makes them look good or makes them look bad. Here's what we did. We turned around, and this is a normal tooth, and you can see what I was talking about here. I'd have to wax all the way up to here. But what we did, we close that up, and now I can make my interdental papilla here. So it's more natural. And I don't have that big gray area that's going back and forth here. So if I go back, that's what I had with normal denture teeth. With these, it closes it up. So that 3D body really does a very, very nice job. If you're doing implants and a bar, man, that's a big difference there. It hides the bar, so you don't even have to opaque the bar. It's kind of real nice, very aesthetic. The next tooth is our Vivadent SPE and the Vivadent SDCL. They're the same tooth line, but they're a little different. The Vivadent SPE is pearl effect. That's what the PE stands for. You're going to find out that you have a little bit warmer, dentin area. So you're going to have a little bit more chroma with these teeth. The Vivadent SDCL, they're both made out of double cross-link material, which is the material that it doesn't surpass the Veneris teeth, which are composites, but they're so close, to wear that you're going to get a, very nice wear out of it. Will I get more wear out of Veneris? Yes. If I'm going against natural dentition, I want my Veneris teeth. If I'm going against denture, okay, I can use Veneris. I can use the Vivadent S PE or the Vivadent S DCL, or I can use the blue line teeth because they're against each other. But against natural dentition or crown and bridge, I want the hardest tooth I can get. That's my Veneris. Then my DCL teeth would be next. So if you look at this, you can see also, look at the opalescence here. Opalescence. Look at the surface texture. This is exactly the same surface texture that the Veneris teeth have. So if you like the texture of the Veneris teeth, but you want a tooth that's not a composite, you may decide that you just don't want a composite tooth. Then yes, this would fit the same way, and it has the same aesthetics. It is a 4-layer tooth. The PE tooth is a very 4-layer, and you can see how, a little darker neck, a little rich dentin, and you can see the opalescence. The opalescence actually comes all the way down like a natural tooth. Most denture teeth do not. You have a gray incisal edge. One of the largest manufacturers in the country. I used their teeth probably the first 12 years. My last 20 years, I never used their teeth. I saw the Ivoclar teeth and could not believe the vitality and the natural look of those. So I have to say, I stopped using those. But I do know that a lot of people like them. So they have a good market share. But I love the mammillines, but I don't have gray incisal. I don't have a gray incisal. I don't have a gray developmental line. The largest manufacturer also, if they go outside with a denture tooth, they have a gray edge and they have a gray line here and a gray line here for developmental growth. It looks like a window pane. I mean, you see the window pane effect of having, the window panes in your house. I just don't like it. It's sad to say that, but they're just not natural. And then, of course, we got our blue line. With our blue line, we have the same nice opalescence. We have the nice contour here, but we don't. We do the same as other manufacturers. We have shapes. So you got square, tapering, and ovoid. We did not make this a 3D body like we did the Veneris and the Vivadent S and the Vivadent SPE. So you would have to bring your interdental papilla up a little higher. But it's still, this is my workhorse. We probably sell 70% of Blue Line DCL. And there's a reason for that, and I'll talk about it in just a second. The lower anteriors, I really like. It is a flat, slanted incisal edge. And why I like that is when you're going to incise, it's kind of like a ramp. If you have a patient that sews, that's exactly what you want. You want that ramp. Because if you have a rounded edge, they can't bite the thread. They can't, they can't incise their food very well. I like how this slides so smooth instead of having a rounded edge. So I really like that. These are definitely 4 bleach shades, the Vita A to D shades. This is why most people use them. Number one, we have every mold. I'll show you some more molds in a few minutes. This line here has the most molds. I can match Densify molds. I can match any kind of molds. I mean, Vita molds, I can match them. We have so many anterior segments to pull from. But the biggest part is we have all of the occlusion. We have this monoplane tooth that you can never tell that this is a monoplane tooth. Then I also can take my upper 30 degree and I can do like a lingualized contact with a monoplane, or I can do my upper lingual, which is a 30 degree, against a 15 degree, so I can not lock in the posterior occlusion, because you may have some patients that always come forward. You know, they just got that movement. They're always going to come forward, so you don't want to lock them in to intercuspading. So I want to have freedom. So I would use something like this, the 15 degree on the lower, and it will slide and move forward, and it doesn't, you know, affect the patient. And then of course I've got the 22 degree that will have to cuspate. So we got everything there. So everybody loves that it's all Vita A to D shades, it's the bleach shades, everything is good. So we sell a ton of these, and I use a ton of these, especially if I'm going to want to, you know, if the porcelain with all that glass and all in the composite, if I think they're going to chip or break, or I have a elderly patient that may shake a lot and drop things in the sink or things of that nature, then yeah, maybe not use that. If I got a patient that's bad about chipping, dropping teeth, yeah, I'm going to either go blue line, or I'm going to go the Vivadent S DCL or the Vivadent SPE, because they're all the same materials. They're both double cross-link. Anytime you want to use teeth, stay with double cross-link. Don't use single unless there's a reason for that, and definitely don't use a regular PMMA, because your wear is not going to be there. This is the other reason why these are so popular. Back in 2000, and I think maybe 4 or 5, I can't remember the date. Everybody was using the Densify teeth. Every university pretty well had the teeth using it. All the VAs, military. So we decided that we want to get into those universities and those institutions. So we just turned around and said, I give up. And we actually turned around and took the Densify 55D, turned around and changed the labial surface. We put more striations on there. We made an opalescent incisal edge instead of a gray incisal edge and a gray developmental groove. We made them aesthetically better, but the shapes are identical. It's just like you saw with Christy, with that patient. She had a 22E Densify. We would have used a P6 on the blue line. I actually used a Veneris 62 soft, and I actually changed the morphology of the incisal edge to make it fit the way she wanted it to look like. So I still use my Veneris teeth because she has implants. I definitely wanted the Veneris strength to go for my implants. Now we've went over through the whole thing. We probably have 15 minutes so that I can do some questions or some answers. And I apologize. I wanted to show you videos. Hopefully, if you get the kit, you can have those videos, or Kelley Dental Lab can possibly send you the videos. I will make sure they have those videos that you did not get to see, because I wanted you to see Dr. Frank doing all this clinically, but we had an issue with those, and they wasn't working properly, so we apologize for that. So I just had to ad lib and do it the hard way. So I hope you got a lot out of that and you enjoyed it. I want to thank Amy. I don't know if Amy wants to say anything or not, but we appreciate Amy and Kelley Dental Laboratory. My cell number is here. You've also got Amy's telephone number up. I'm sure you all have her phone number already, and to call them, but you're always welcome to call us. So I wanted to see if there are any questions. Pat, if you've got any questions and I can't hear them, if you'll type them, Pat should be able to pass them along to me. Hopefully you may have been sending him questions and he's been answering them all along. I'm not sure because I can't see that part tonight.
Don, we currently have no questions. We have no questions currently, Don. But if anybody has any, please give us a little type it in over in the chat box area, and that'll come to me, and I'll pass them along to Don.
So we'll wait a minute. I hope you all are still with me. And if you have any questions, you can let us know. If you have questions and you don't want to type and you do not want to ask, then please, get with us later. You'll also be able to take the 5 CE questions and then answer those so that you can get your CEs. Pat, was Amy able to either say anything or anything?
Yeah, I think they're going to come on here again. If they'll if they will unmute and turn on their webcams, they will be able to come in with us. I've also got a couple questions coming in, Don.
Oh, good.
The first one is regarding the centric trays. Are those
Yes.
single use or autoclavable?
Oh no, they're not single use. You go ahead and just cut your material away, and then they're definitely autoclavable. So don't throw them away. You purchase them once and keep reusing them and sterilize them.
The next question, Don, is does Ivoclar also make a gingival acrylic shade guide, or is that acrylic from a different company?
No, we definitely make shade guides. In fact, we have US Light, we have Pink, we have 34V, we have Preference. Preference is what matches the original 199. So it's not the 199 that kind of started, changing a little orange. It's definitely got a nice color to it. So Preference is the closest match for that. But we have many colors and it comes with a little shade guide. If I'm not mistaken, and Mike can tell you for sure, Mike Lawler, he can tell you what the pricing is, and I'm gonna stick my foot out there. I think they're around 12 or 15 bucks just for all the little tabs, shade tabs for you. Any more questions, Pat?
Those are the only 2 questions I've got right now. So.
Well, great. I do appreciate everyone coming with me, and I think you're going to let maybe Amy talk. And thanks, Mike, Mike Lawler, and Christopher Giles. Thank you all for what y'all do. And hopefully you guys are going to be talking here in a few minutes, and I'll be quiet.
Thanks a lot, Don. I'll hand it to Amy, and then she will to Chris Gillis.
Okay, thank you.
Awesome. Thank you, Don. That was a great presentation. We really enjoyed it. Thanks everybody for being here. This was one of our first webinar CE events. We're used to seeing everybody in person, so we appreciate everybody being here. It's been nice because we've had some people from further away than that were able to attend tonight. So thank you very much for being here. We have a couple parting gifts for you, and we'll be following up with you via email as well. I have a little drawing here. We do have a smile design kit here at the lab. We are going to give one of those away tonight. So I'm going to draw for it now from our attendees. And the winner is Dr. Nathan Thompson. So we'll send you the smile design kit, Dr. Thompson. So you'll have all of those tools that Dawn shared with us tonight. And in addition to that, for your next cases that you do with us, your next injection Ivoclar cases, we will be giving away a set of centric trays. We feel like that'll really help you guys save time in your practice. And that's really what we're here to do, is to help you and help improve your practices. So anything you need from us, please reach out. And I have one more offer on the table. I work with a business coach, and she was very excited about our webinar tonight. And she has offered a free business evaluation for anybody that's interested in taking their practice through that with her. And I will get that information to you also via email. So thank you so much for being here. You have my contact information. If you need anything, please feel free to reach out, and I'll turn it over to Chris.
Hello, everyone. Many of you probably know who I am already. I'm actually the clinical territory manager for Ivoclar. So I cover all of the direct and indirect products for, so basically once your crown comes back from Kelley and you have questions on how to cement it, that becomes me. So I jumped on here just because I wanted to learn a little bit more and kind of see this work. I wanted to put my number on there in case anyone want to get in touch with me, but I'll just give it to you if you guys have a pen handy. Hopefully you'll have time to write this down. I'm actually stationed out of Louisville, and my number is 502-552-1345. I go into part of Indiana, not the whole state, but part of it. But if you reach out and you're in someone else's territory, I'll get you in touch with them. We've got many great new products on the clinical side as well, for direct and indirect restorations, curing lights, and what have you. So if anyone has any questions for me, please feel free to reach out directly, and I guess I'll give it back to whoever's next.
Who's next, Pat?
Sorry, I think that's got us. We don't have any more questions coming in. But yeah, I think that will take care of us for the evening. Just a reminder for everybody, again, we will be offering some CE credits for this. You should be getting an email with the email that you use to register for the event. Just follow the link in there. It'll take you to a little questionnaire. You'll do a quick little quiz, and then you should get another email within a few days with your CE.
And of course, thank you again for joining, and try this. I think you're going to be totally surprised. You're going to find out that dentures are not what they told you they're like. They're going to be very successful. They're going to be very predictable. So thank you, and you guys have a good evening.
Thanks, Don.
Thanks, everyone.
Thank you.
Thank you all.